This is Dr. Sebabrata Jana, an interventional cardiologist attached with SSK Hospital and IPGN. Today in this session, we are here to discuss about latest update in hypertension. To start with, as per WHO, nearly 63% of total death in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affect 45% of people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for cardiovascular diseases, and moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and very poor follow-up. If we see, the prevalence in India of hypertension has gone up over last 30 years. It has reached from 29% in male to 38%, and in case of female it has gone high from 28% to 32%. Despite that, nearly half of people, or if we see the exact figure, almost 51% of men and 41% of women with hypertension are unaware of the condition. And additionally, over 62% of men and more than 53% of women are living with hypertension without getting any treatment for that. Medication was used to control blood pressure in fewer than 1 in 5 in men and 1 in 4 in women with hypertension. This is the worldwide scenario according to Lancet guidelines published in 2021. If we see International Society of Hypertension, they have released the ISH 2020 Global Hypertension Practice Guideline. They included the optimal and essential treatment paradigm in an attempt to address the issue in resource-poor settings. Now, optimum care refers to evidence-based standard of care, whereas essential care means it refers to minimum standard of care to allow specification of essential standards for low resource settings. If we see the ACC-AHA guideline 2021, they are offering new guideline for management of stage 1 hypertension with low ASCVD risk. Low ASCVD risk means either there is no ASCVD risk or a 10-year cardiovascular risk is less than 10%. With stage 1 hypertension means systolic blood pressure in between 130 to 139 and diastolic in between 80 to 89. The management starts with non-pharmacological therapy. Now, if the blood pressure remain uncontrolled even after 3 to 6 months of non-pharmacological therapy, then you can consider starting pharmacological therapy. If we see, lowering systolic blood pressure target down to 110 to less than 130, with this range substantially reduce the cardiovascular adverse event in step randomized trial, which affirm the sprint finding for an older Chinese population. Among almost 8,500 patients aged between 60 to 80 in China, the intensive target trimmed off around 26% of composite cardiovascular adverse risk. Finding from now a second major trial supporting the lower BP target that can unite the guideline. If we see with regard to prognostic value, the ambulatory blood pressure monitoring and nighttime blood pressure monitoring, the 2018 ESG guidelines for the management of hypertension, they have recommended the diagnosis of hypertension should not only be dependent on office blood pressure, but also on out of office measurement such as ambulatory blood pressure monitoring or home BP monitoring. The 24 hours blood pressure monitoring or nighttime BP measurements were associated with greater risk of mortality reduction and reduction in composite cardiovascular outcome. Thus, they may be considered that most relevant measurement estimating cardiovascular risk. For every 20 by 10 millimeter of increment in blood pressure at night, the mortality increase almost 23%, and the risk of cardiovascular event increased by 36%. So most patients in hypertension require long-term medical therapy to achieve the optimal blood pressure control. That's why the 2018 ESC guideline has recommended 5 classes of antihypertensive drugs. For this very particular reasons, the importance of combination treatment is particularly highlighted to improve the adherence of therapy and to have intensive blood pressure control. Therefore, 2018 ESC guideline recommends, especially in the context of low BP target, to start with a fixed dose combination with ACE inhibitor or ARB along with a CCB or a diuretics. Now, since HYGEA study, they represent the largest study that tested the nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual awakening hypertension therapy exert a favorable CV reduction or not. The largest study included a 19,000 hypertensive patients, and during an average follow-up of 6.3 years, almost 17 and 52 participants experienced a primary cardiovascular outcome. An ambulatory BP measurement was performed for 48 hours to collect on how blood pressure differed during sleep. And the relative risk reduction for cardiovascular event was significantly improved for nighttime treatment when it is compared with the daytime treatment. So this much about the latest update about hypertension. Thank you all for kind hearing.